Good afternoon, everybody. Thank you for taking the time to join us for today's webinar. My name is Cedrian Martin. I'm the Communications Advisor for the UNAIDS Caribbean Sub-Regional Team, and I'm also the Chairperson of the PANCAP Knowledge Management Working Group. I'm pleased to be your moderator for today's webinar, and I'm also going to give a brief presentation to set us off in terms of establishing where our region is in terms of testing coverage and what are some of the strategies we can employ to get us where we need to be by 2020 and beyond. I extend a very warm welcome to all of you on behalf of the Pan-Caribbean Partnership on HIV and AIDS and PANCAP's Director, Mr. Derek Springer, as well as the PANCAP Knowledge Management Working Group. Thank you so much for joining us. Before we start, a few logistic and operational notes. All your mics are muted. So if you have a question while the webinar is in progress, please type into the chat field. We'll be monitoring to ensure that we could flag those questions and get some responses to you. The other thing is that we'll get to the questions after both presentations. So again, as the webinar is in progress, if you have any thoughts, if you have any inquiries, just type them in. We have two polls for attached to this webinar. We encourage you to participate. You'll see as those pop up into your screen, and you could fill those out immediately. And as usual, at the end of the webinar, there will be an evaluation that will be sent to your emails. And we just urge you to take a couple minutes to give us some feedback, because we really value your input about what works, what doesn't work, and how we could do a better job. Just a note that the webinar is being recorded and it will be shared on the PANCAP's website for the greater benefit of the entire partnership. So if it's a resource that you would like to come back to or to share with others, it will be available to you on the PANCAP website. So I will kick things off, and just to confirm that our topic today first is how close is the Caribbean to the first pillar of the 1990 cascade. So just about a week ago, UNAIDS launched a global report focused on the issue of knowledge. Knowledge is power. So this report actually focused on the issue of HIV diagnosis, as well as viral suppression and viral load monitoring. And so we urge all of you to go to this resource to see where the Caribbean stacks up in relation to the rest of the world and what some of the recommendations are for getting us all as a global community closer to reaching both the testing target and the viral suppression target. But today we're really going to focus on that first pillar. Just to note that across the world, 75% of people living with HIV are now aware of their status. In 2015, just a couple years ago, that number was at 67%. So the entire world is making some progress as we are 2 years away from the 2020 deadline. So in the Caribbean as well, you can see that in this slide, we see where we were in 2015, which was just around 61% of people living with HIV aware of their status. In 2016, we went up to 66%. And in 2017, we were right around 73%. So we're still a couple percentage points behind the global average. On the one hand, it seems like that's not much. We're almost on par, but really, we have to be committed to accelerating progress, because our success in terms of achieving all of the 1990 targets really relies on how well we do with the first target. So just to explain this slide, the first column is testing, people who know their status. The second group is those who are on treatment. The third group, those who are virally suppressed. The beige color represents our 2017 findings, results for the Caribbean. So in 2017, as we know, 73% of people living with HIV in the Caribbean were diagnosed. And that goes on to 79% of those people were on treatment, and 70% of those on treatment were virally suppressed. That's looking at the beige column. And of course, we see that there is progress from one year to the other, modest progress when you compare 2015 to 2016 and then on to 2017. There's a little issue in terms of viral suppression from 2016 to 2017 in the Caribbean. So that is another issue that we have to pay close attention to, because in fact we are quite far behind the global average of 81% virally suppressed. So this is another area where the Caribbean really does have to accelerate progress. But the key takeaway that I want here is that our success on treatment, our success in viral suppression, first and foremost depends on whether we could identify those people who are living with HIV. And so we really do need to scale up on the first pillar. When we look at the same numbers, but when we look at the treatment and testing cascade, which basically uses as its denominator all people living with HIV, this paints a slightly different picture, in that right now we're at just about 57% of all our people living with HIV on treatment, and about 40% of all our PLHIV virally suppressed. So if we don't do a much better job on our first pillar, then necessarily we're going to have lower and lower and lower results further down the cascade. Basically, a gap in diagnosis is going to undermine all our other results. In terms of the target, from the end of 2017 until 2020, the Caribbean is going to have to newly diagnose 54,800 people who are living with HIV. So that's the challenge before us. What do we need to do differently in order to reach a little more than 1 in 4 PLHIV in our region who are walking around and don't know their status? And just a quick mention, just over 74,000 we need to get on treatment, and just over 100,000 that we will need to be virally suppressed if we're going to reach those 2020 targets. So what's happening in the Caribbean? In 2017, this is a huge red flag that fully a quarter, 1 out of 4 of all our new HIV diagnoses were late. So we still have a situation where, although testing services are available, they are free, they're in the private sector, they're in the public sector, NGOs are providing the service, we still have people who are only being diagnosed when they have at quite an advanced stage of HIV disease and illness. And so this is something that is a huge red flag for our region. And one of the trends that we've seen is that among this group, among that 25%, many men, predominantly men. So this is something that we need to pay attention to in the Caribbean. How do we ensure not just that people are diagnosed, but they are diagnosed as early as possible so that we have the opportunity to initiate treatment and the opportunity to prevent new infections. Just keeping in mind that we had 15,000 new infections in the Caribbean last year. If we diagnose people earlier, we can prevent a lot of that harm. The other issue, and this goes beyond men, for the general population, what is it about testing? It's quick, it's easy, it's safe, it's effective, you get your results in 15 minutes. Why isn't everybody getting tested and finding out what their HIV status is? And so we asked this question in 8 Caribbean countries in a survey done a few years ago, between 2013 and 2016. And the most common reason that people gave for having not been tested is that they're concerned about the stigma they would experience if news of a positive result gets out. So in 2018, we are still contending with the challenge of people thinking, oh, well, I'd rather not know. I'd rather not know if I'm HIV positive, because how am I going to cope with the way I am treated? And so, as with all of our interventions, it's not just about providing the services, it's also about creating that enabling environment, helping to push attitudes along, helping to shape a culture in which people are supported to understand, listen, this is a part of routine healthcare. This is something that I need to do as a sexually active person. If I'm HIV negative, great. I'll come up with a strategy to keep negative. But if I'm positive, it's not the end of the world. There's treatment for me. There are resources available. I can not only live a healthy life for myself, but I could also prevent transmission. So we need to get this message out so that we could change the culture around HIV testing in the Caribbean. Another big concern, confidentiality. We know that our healthcare workers have done a lot of work to increase confidentiality. We know that there's been lots of innovation around training, around sensitization for all workers, including auxiliary workers in the healthcare settings. So part of our challenge is ensuring that we keep up the momentum, ensuring that we keep retraining. But then there's also a question of how do we get the word out to people that, listen, there has been progress. Steps are being made. There are avenues for redress. There are systems in place to ensure that your confidentiality is kept intact. And then a third reason, people are uncertain about how to handle a positive result. And this is an interesting one because this goes right to the core of the services that our community-based organizations provide, the services that our NGOs provide in terms of psychosocial support, in terms of care, to help people with precisely this. It's not just about taking a pill, it's ensuring that you have the emotional, the mental support to cope and to move on and to thrive. So when we have a holistic approach and when we communicate that to the people of the Caribbean, we're going to have more and better testing uptake. Now, of course, we know that among the about 1 in 4 people who do not know their status, we're going to have many people who are in our key population groups. There are huge variations. Some countries are doing better than others in terms of getting to key pops with testing services. Just as an example here, we have 4 countries with data on men who have sex with men. So quite high rates of knowledge among MSM in the Bahamas. Obviously, they have access to testing, there's high demand, and they are going out getting tested, they know their status. In contrast, the latest data from Grenada shows fairly low levels. So we know that one of the things that we have to do is develop strategies to specifically meet the needs of our key population groups. And not just the key pops, but any vulnerable and marginalized group, and I would say here, including young people. We need to think through what can we do to reach people where they are? What can we do to address the barriers that are relevant for particular communities? And then switching gears just a little bit, there are also wide variations in terms of early infant diagnosis. So we see very high levels in Cuba, very high levels in Trinidad and Tobago, and lower levels in some of the other countries. So this is just a reminder that when we talk about EMTCT, it's not just testing the mother during the pregnancy. Many of the countries also need to focus on the follow-up and strategies to ensure that infants are not lost to follow-up and that we detect cases early. So I'm going to share a couple of the strategies that we are now recommending globally to ensure that we close the gaps and safeguard the right to health for people at risk of HIV. The first strategy just spoke a little bit about it, point of care, early infant diagnosis. There are new technologies available. They are reducing the time between taking the blood sample and providing the test result to caregivers. And so when we have that faster return of results, it reduces the number of children who are lost to follow-up, and we have more rapid treatment initiation where it is necessary. So this is a strategy that's being recommended. And as we just saw in the previous slide, some countries have a system that works, and there are other countries that do have some improvement to do around this particular task. The other issue, big push for community-based HIV testing. There are lots of logistical, structural, social barriers for HIV testing for different communities. Community organizations are best placed to clear some of these hurdles. And for example, one of the strategies is even using home-based testing delivered by community care providers in high prevalence settings. And also a strategy that has worked so well in the Caribbean, and I know we'll hear a little bit more about it later on, peer outreach to adolescents, to young people, to key populations is really effective in terms of increasing testing yield. The other strategy that's being pushed globally is index testing. And in not the last webinar, but the one before, we heard some really promising updates about the rollout of this strategy, particularly in the Dominican Republic. Basically, in a nutshell, index testing is once you have somebody who is tested positive on a voluntary basis, their sexual partners, their children, other household and family members are also engaged to be tested. And the findings throughout the world are that this is a really effective way to reach groups that are less likely to seek voluntary counseling and testing. And this is particularly important for men and for children. So another strategy for us to focus on. And then finally, the whole issue of self-testing. We already know how many pharmacies throughout our region are already selling home HIV testing kits. We've heard in one of the webinars from Ayana Sebro in Trinidad about progress toward developing some kind of policy around this particular intervention. We have an update from Brazil, which last year led the entire Latin American Caribbean region in terms of the government coming out front and saying they're going to regulate self-testing in terms of the types of tests being offered by pharmacies, and also in ensuring that there are resources available. So whether people test positive or negative, they have the information at their disposal about what their next step is. And so you don't have that fall off. People are able to be linked into care after being tested in the privacy of their own homes. So those are 4 strategies that may prove useful for the Caribbean as we move forward. I'd like you, if you have any questions as the webinar goes on, please feel free to put them in the chat box. I'm now going to switch over to Margarita Elliott. And I'm looking for Margarita. Timothy, I know you're on the other end. Please, by the time, could you, Margarita, the presenter, please? And so let me do a brief introduction for Margarita. Margarita's topic is increasing and improving key population testing uptake in Trinidad, implementing approaches to drive demand creation through the USAID Linkages Eastern Caribbean project. Margarita has more than 20 decades of experience in development work. She is currently the program advisor for the Linkages program in Trinidad. Since 2017, she'd been working with the project in the Eastern Caribbean. She's had a couple roles, capacity development advisor and project manager, which she is currently. She has worked locally, regionally, and internationally in policy formation, strategy and framework development, gender mainstreaming, capacity building, program and project management, humanitarian diplomacy, and community health, to name a few areas. And all of us in the region would have known Margarita from her days at the CPAC network, from her days at the Red Cross, from her days with the Trinidad and Tobago HIV and AIDS Alliance. So really a wealth of knowledge and experience. And just to mention, she has a law degree from the University of London, postgrad diploma in humanitarian diplomacy from the University of Malta, and is currently pursuing a master's in public health from the University of Roehampton. She's still studying. Wonderful. So Margarita, with that, I turn over to you to give us this insight into increasing and improving KP testing uptake in Trinidad.
Okay. Thank you very much again, Cedrian, and good afternoon to all who are listening and streaming in on the web. It's really a pleasure for me to be part of this process, and by extension, on behalf of the Linkages project, which is a global compact focusing on key populations, as a project of USAID, which is currently being implemented by FHI 360 in different parts of the world. So it's really a pleasure for me to be part of this exercise in the Eastern Caribbean, and more so for us in Trinidad to get this population into the treatment, the public health mechanism, using a community-based approach to the way we use our strategies and the overall framework. So I would just briefly give you an idea as to what the Linkages project is. It's really a project working in partnerships with different stakeholders, governments, key population organizations, among them private sector entities, and different entities who operate within the community of practice working on HIV. The focus of the Linkages project, again, as I mentioned before, are key populations who are men who have sex with men, sex workers, people who inject drugs, and transgender people. The aim is to extend their life. It's to get persons in, get persons tested, get them enrolled in care and treatment. If they are positive, ensure that they get onto treatment as quickly as possible, which, you know, we all have this end game and this end goal of getting persons virally suppressed if they're HIV positive. So here you'll see a lovely picture, and this is the team of persons who are on the front line in Trinidad. I cannot express how hard these people work to get in the goals of the project realized, meeting our targets and providing a quality service to persons who need it. So again, the Linkages project is around results, and we use our results as our guiding posts. One is to increase the availability of services. Two, to increase demand for HIV services, and that is what I'm going to be focusing on today. And then three, looking at the strategic elements that are necessary to drive a project like this, which essentially builds the overall capacity of the HIV mechanism to maintain and sustain the approaches. So quickly, some of the guiding principles, again, we're looking at structural barriers, stigma and discrimination featuring highly, also violence. We need to also ensure that our project is context driven. The issue of high quality cannot be underscored enough. the importance of using data to inform your decision, and to also understand and appreciate that you need to be flexible, you need to be dynamic, because we do have a one size fit all. And of course, building and facilitating the capacity of organizations and persons who are from those communities to be able to lead and to drive their own development. So the project is a 5-year project. It is funded by PEPFAR USAID. It started in June. And for some of us, some persons who may be familiar with PEPFAR and USAID, the support for AIDS has, transformed over the years. And I think the last when we realized, and we did an analysis of persons who were coming in, we realized key populations of persons most at risk at the time were the ones who are most impacted by HIV, but they were the ones who are most likely to spread HIV. So PEPFAR at the time focused their resources on getting key populations into the scheme of things. What then happened, after a while, we realized that key populations were not coming in, and that is where Linkages as a compact was created to get persons from the community into the public health sites to provide them with the services they need. $225 million has been pumped into this to resource this, and we are currently active in 30 countries. And of course, we have partners who provide different technical support to ensure that at the end of the day, the product is one that can be all-embracing. So this is just a group map of the spread. Just to also underscore, based on what Cedrian had said before, we subscribe to the 1990 cascade. And this, as we know, it helps us as a globe to align, to be able to count where you are at, wherever you are in terms of your implementation. So again, as we look here, we look at identifying populations. This is where we look at, prevention. We need to know where people are. We need to be able to identify them. We need to touch them. In terms of reaching key populations, it is not necessarily an easy feat. So we need to have approaches to help us to get to that place. And of course, we need to get them persons tested so that they know their status. Now, this side of the cascade speaks to when someone is HIV identified as positive, to get them quickly into care and treatment. Now, they may not necessarily start right away because they may have other challenges that you need to treat with. And once those are treated with, we understand the nature of their illness, we could then initiate ART, antiretroviral therapy, and the drugs. We make sure we provide all the support that is needed so that they are sustained on ART, and of course the long-term goal of remaining virally suppressed. As you know, as I mentioned before, we speak to community engagement, and that is critical, and that is the hallmark and the crux of Linkages. And of course, capacity building, because for most projects, means that you start at one point and you end at another point. But what happens in that space, you have to ensure that the gains from the project are not necessarily lost when that project expiration date comes along. So we have this approach around capacity building that treats with those issues. And of course, to have that enabling environment, as I said at the top, we need to have all stakeholders on board. So from a human rights perspective, once those things are taken into consideration, you look at gender equality, you also look at equity, and of course, the issue of stigma and discrimination and violence, which influences everything around key populations. So what do we do to reach people? How do we identify these populations? So some of the approaches we look at is, one that I want to talk about is hotspot mapping. And this is where we try to identify where people are at. So you see people might be in their homes, they might be online, they might be on street corners, and they may operate in spaces that they consider to be safe, or where they more than likely would meet other persons like themselves. Again, here again, hotspot mapping, you see where it's focused around prevention. And of course, you have to make sure that you align it with the cascade. So some of the types of hotspot mapping, there are physical hotspots, which we do provide training for our outreach team. We did provide them with training. They can go out. They know where KPs live, where they hang out, and where they go to meet other members of their community. There's also the online aspect of hotspots, and we do, based on what we've done on the project so far, we are very aware of where those hotspots are in Trinidad. So then what we then do based on the information we have from from hotspot mapping, and we also do a little bit of size estimation based on official data. And that in itself is a challenge, which I will speak about when I speak about the challenges. We then sit as a team and develop our approaches, and it's really around microplanning. And again, it's at the prevention stage, and this is where we focus on reach, and we focus our planning in a focused, intense, contextualized manner. So who do it? Our outreach team, we have peer educators, navigators, etc. We have CSO staff. On why we need those persons to lead. They are the ones who has to determine the hotspots and the sites. They are the ones who plan and track against the behavior change progress of individuals. Because when you start talking to people and you have that first conversation, you could guess where that person is, and based on that conversation, then take them on to a risk assessment and then devise a program for them. Not in a case management scientific approach, but one that is in keeping with their language and where persons are at. Again, you support persons in terms of their needs at the time, and you ensure at all times the issue of quality outreach, 100% coverage at all times. So again, this is just a cluster to show you the different elements of the peer educator level. They look at peak work time, they look at the commodities that are needed. Commodities in this sense speaks to condoms, both male and female, ensuring that persons have access to loops. And then you look at the variation within the populations. You also look at their networks and what actually happens around those hotspots. So there are a lot of benefits. Again, data collection, ensuring that when you set a new plan, you are using information. There is a science. You are not shooting in the dark. And you are helping as the outreach team as a compact and as a platform to collectively identify the gaps and to also address some of the success areas or quick wins that you may have. Understanding also that our key populations, they are operating off the radar and on the margins. So it's not necessarily going to be an easy feat. And of course, you want as far as possible to get the ownership and trust of the community. So outreach, we will definitely not be doing these kinds of things, access sex worker. But there are a number of things to consider. Again, some of the same elements I spoke to already. would be considered here. Then we also have something called an enhanced peer outreach approach, which is more or less a social networking strategy where we use persons who are linked to the program to get into their networks. So we have peer leaders, and those are persons who we pay, the salaried workers. They maintain our intern network, and they may identify peer mobilizers, and peer mobilizers could be anyone who also have their peer group, or they are aware of persons within the different communities we are targeting. These persons don't necessarily need a formal training, and they're given coupons and small incentives to do some of the work. And of course, we have the client, and that client is then brought into the program and has the further conversation with our peer outreach workers and our navigators. It's important to look at both social and sexual networks because it is the nature of the work that we are doing. So this is just an example of one of those high-performing programs within Linkages, which is Thailand, where they were able to use this mapping mechanism to then identify where persons are. So you can get a visual of what takes place. And of course, there is ICT, which is online. What we have noticed, especially in Trinidad and Tobago, a lot of our key populations, this is where persons mostly operate. And it follows through from all elements of the cascade, all points in the cascade, from identifying to reach, to enrolling into care, to initiating on ART. The important element, we need to also recognize that when we reach persons, you might be reaching persons who are already aware of their status, and they may not necessarily, they are not necessarily part of a treatment program, or they may have been on a treatment program and have dropped out for different reasons. So we also make accommodations for those kinds of persons. So a little bit about, the data, what has been happening in Trinidad. So for FY18, when I say FY18, I mean financial year 2018, which runs from October 27 to September 2018. We will share a little bit about the female sex workers. And we've seen in terms of reach, and reach in this instance mean having a conversation with someone, getting them assessed in terms of their risk. We also pay attention to their vulnerabilities, and we have a motivational conversation to get them tested. What we also offer at this stage, we offer condoms and loops, commodities, so to ensure that if they don't have or if they need, the next sexual encounter is one that is safe. This is where persons are normally introduced onto the program. And for this financial year, or the last financial year, based on the output and the effort of our outreach team, we surpassed those targets. The target set for the program was 304 female sex workers. Of those we reached, we also got a lot of persons tested, and we also surpassed the targets by 136%. Of those tested positive, 67%, or 2 of the 3 persons identified, were tested as positive, were enrolled in care. And you'd notice at this stage, we also have a newly enrolled in care, which is higher than the 3 we would have identified as positive. What happened, those extra 2 persons would have come from other programs, or they would have been tested outside of linkages, but they became aware of what our outreach team is doing and spoke to them, or they may have gotten onto them to get themselves in on treatment. And based on the efforts, again, we got all persons linked to treatment. So men who have sex with men, we see a similar trend here in terms of reach. Again, surpassing the reach, again surpassing our testing targets, and of course taking everyone in that we would have reached who identified as positive, and including those who came to the program, getting them enrolled in care and getting them linked to treatment. The trans population is also an interesting one, and it's the same trend as per the other population. So what this really shows is based on the efforts that the outreach team have been employing, we are getting persons in. So some of the trends that we've observed, we've noticed like 35% of all persons reached did inform the program that they would have experienced some sort of gender-based violence. There's also the trend of high drug use among all populations. We also recognize a number of comorbidities, meaning especially among MSMs, men who have sex with men, we found like high levels of syphilis in some instances for those who were HIV positive. We noticed too, in terms of sex work, all groups were doing sex work. And there is also that phenomenon among the men who are homeless and who use drugs, would engage in same-sex, sex in exchange for goods and money, only to satisfy their drug habit, and will not necessarily ascribe themselves to a label. What we've also noticed among all persons reached, getting tested is not necessarily a high priority. Whilst it might be a priority for our program, and that is how we can track and gauge our impact on our results, we came to terms early that key populations are not necessarily interested in getting tested. That is not the highest priority. There are other issues that they are concerned about. There are a number of psychosocial issues in terms of the discrimination, in terms of treating with their family. There are disclosure issues, ensuring that they have support. We have a lot of persons who, especially among the female sex workers, who recounted being raped, a lot of untreated trauma, which required persons being referred out of the program, and also the issue of treating with managing their relationships. There's also the online dimension. In the last quarter, which would have been from July to September, 87% of case finding, 87% of persons who were identified as positive on the project were identified from the online approaches. So it's important to acknowledge and recognize that. So challenges for demand creation programming, the high levels of risk among key populations, challenges with access to these populations, some of the structural barriers that exist in health, meaning that sometimes these spaces are not necessarily friendly. It's not organized to get persons trusting of not only the institution, but the persons who provide the services. The issue of service continuity. Nobody's checking up, nobody's ensuring that persons go on to the next phase. So when they go in, they get a HIV test. In some instances, they're given a piece of paper, and in some instances, they are told, okay, you are HIV positive, and they may get the counseling, but no clear path towards the treatment site. The issue of societal stigma, that also influences the treatment persons get, not only in health, but in a number of the public spaces where they would have to engage to get services. And in some instances, post-discrimination redress. So the police sometimes are not necessarily friendly. If you are raped and you go for different services, the feedback you get is not always a positive one or a positive experience. And a lot of times those experiences leave people scarred. The issue of having current and updated information out there in the public, it remains an issue. What is online? A lot of people are feeding from online, and sometimes the information is controversial and may not necessarily always be correct. And those pieces of information are then taken into, and then people use those information to make decisions about their sexual health and about their life, and it affects what then happens going forward. The issue of illegality, it surrounds KP existence, especially for sex workers. Prostitution is illegal. Same sex among men who have sex with men up till April was also illegal. So it is a challenge. And even with the passage of, or the pronouncement by the court on that, the pieces of law which would have legitimized the stigma and the discrimination, a lot in the space has not necessarily changed to match the pronouncement. In fact, in some instances, when the judgment was read, Jones versus the state, we had a lot of negative kickbacks that we had to deal with. Persons being evicted from their homes, a lot of persons lost their jobs because, of course, it was highly publicized on the media, and a lot of persons could have made out who were involved in the protests and so on. And of course, the issue of national data and surveillance. In a lot of instances, we do not have current data for the populations that we are targeting. So in terms of female sex workers, where is that data? Who is collecting it? How dated is it? Those are question marks and challenges we have to treat with, because you need reliable sources of data to plan your approaches and to plan your program. And it's the same for trans and for men who have sex with men. Excuse. So what have worked? What have worked on linkages? Definitely peer-to-peer approaches. The members of that outreach team, I call them a motley crew of people, simply because we don't have two persons who are similar. They don't have the same background. They don't come from the same spaces. They belong to the populations we are trying to reach. Having access to the populations that we are targeting also makes a huge difference. The issue of trust and confidentiality by the populations we are targeting in or on the project itself it's also critical, so that when someone comes to any member of the team and say, I need you to go with me to get tested, or I need you to go with me to speak to my doctor at the treatment site, that speaks volumes. in terms of the value that the project is bringing to the space. What also helps is having good data collection, a proper M&E system where you can collect the data to inform your decisions. Knowing fully well that persons may not necessarily disclose when they go to a public health site, having persons sharing their information with us and treating with that, that also impacts on the products that we are able to offer the space. And that's it for me.
Thank you so much, Margarita. Really great food for thought. We have just about 10 minutes for questions. So I encourage you to type your question into the chat box. Let's see how many we can fit in the next 10 minutes. Really excited to get some more information about this very interesting project. So one question from one of our attendees, Margarita, do you ever encounter anyone under 18 years? How do you deal with them in terms of going for treatment if they're found to be positive?
Right. So we have encountered persons who are under 18 in the past. What we do guide our navigators and educators to do, we have to stop because we can't take them further. And what we then do, we do referrals to um, the public health sites because they are the one, they know how to treat the issues around children.
So what generally happens next? Is a parent or a guardian contacted? What happens next?
When we share the information, um, their parent or their guardian are contacted. There's also the issue of the GILIC guidance that the public health, and I want to underscore the public health workers are well trained to implement, where based on the age of the child, the severity of the issue, they can um, they can treat the child, at least within the law.
Okay.
It's something that we always have to be telling people about because some of these, especially with the sex work element, we always have to be mindful of children. And it's an area where we have a lot of young people sometimes to tell you that they are 18, or then you look at them, you can tell sometimes that they are not necessarily 18 and they're younger than that. So a lot of conversations around that in terms of our team meetings and so on to guide our outreach team because things can go wrong.
Got you. I noticed that you mentioned that some clients actually go on to become peer leaders. And it made me think, can you tell me some of the success stories, like one or two stories of people who have thrived in terms of learning that they're positive, but then moving on to be leaders for their communities?
We've had a couple of persons who so we had one navigator did share with us, and we also have a published success story which will be out soon. That person came onto the project last year, October, when their first HIV test was identified as positive and was virally suppressed by June of this year. What then happens, based on the quality of support they receive, they then tend to refer their friends and other persons to the program. We have one of our educators who came on as a peer mobilizer and is now a peer educator. So we have wonderful success stories where persons understanding the importance of what linkages has provided for them, and because it's so differentiated, it's focused on key population, we emphasize the importance of one-on-one support And it has been of that kind of quality where persons say, okay, I'm here, I want to be part of this process.
Gotcha. Just a reminder to all our participants that the quick polls are up. So just a few quick clicks. We'd like to get your feedback on those polls. Another question for Margarita. You mentioned the range of challenges, psychosocial challenges, sometimes homelessness, medical issues, drug use that people are contending with. So give me an idea about the interventions that the Linkages program would make to get people prepared for treatment.
Right. So, especially for the drug using population, um, we because persons are placed. When I say persons, our outreach team are placed at different places. We know who we can go to get someone a bath, to get someone a meal before they could actually go to the treatment site. Um, we have to make sure that for those who are on drugs, we also treat with their drug use before they could actually start the treatment. So it's not, it may look, when you look at the screens, you may see numbers. Each number is a human, a person, their life. It's a life that you're dealing with. Um, so we treat each person the way they come through the proverbial door. A lot of times there isn't a physical space, you meet them where they are at. Um, and it's important that the approaches we use for the outreach team to speak in their language, to understand their context, their reality, and to do so from a place of compassion and understanding. Sometimes a person may miss a critical appointment. It means that our outreach team may have to go with their class, find persons, transport them, so sometimes spend a whole day navigating persons through the different um, needs they may have, or the service providers they would need to engage to get to the best place in terms of their treatment goals. So we continue at different points with different people who may have different needs. And again, falling back on the network that we have in Trinidad, that also helps us as well.
Now, that approach sounds so intensive, Margarita. I think it raises a sustainability question because you mentioned that ideally this should be something that is sustained beyond the existence of the project. What should countries be doing to ensure that this kind of intervention could be delivered on an ongoing basis?
So again, that whole there's also a global conversation around what is the best approach for technical assistance, where the technical assistance is coming externally. Um, it also we need to also look at the concept of skills transfer. It can't be, okay, someone is coming in who has this wealth of information, but the importance of the approach whereby we train persons and they remain with the information or the methodology, and um, they are then given that functional element to then replicate, and it stays within country. It's important too that whatever we are doing, we collaborate and work closely with the authorities. So the Ministry of Health plays a critical role. In our context in Trinidad, the National AIDS Coordinating Committee also play a critical role. And we have something what they call a technical steering committee. And that is where the technical approaches on the project are exercised, it's fleshed out. We also have discussion around the different sustainability models, and we are into that phase now in Trinidad relative to the Linkages project. Where we are exploring the appropriate models that we may employ going forward, because at some point US government resourcing would end, in this context, in the linkages context. So we need to make sure that we don't leave people in a vacuum,
Mhm.
that we leave Space Trinidad with a number of legacy pieces that they can use, that is user friendly, they can use it going forward, and they can take those on to then inform the national response um, in terms of HIV, but more specifically to reach these populations. Because the same approaches will not necessarily, the same approaches we use the general population will not necessarily reach the population.
Okay, we are just up on half past the hour. I have more questions. More questions. But Margarita, I want to thank you so very much. That was very informative. I think the fact that there's still more questions to be answered is a testament to how interesting and engaging the presentation was. Just a quick thank you to everyone who took the time to join us for this webinar. Just to remind you of the short evaluation survey that will be delivered to you via email. On behalf of PANCAP and its director, Derek Springer, and the members of the Knowledge Management Working Group, we'd like to thank Margarita for investing her time and expertise, sharing her knowledge with the partnership. Thanks to all of you who joined us today. And just a quick reminder that the webinar has been recorded and will be posted to the PANCAP website. Finally, we encourage you to stay engaged with the regional response. Follow us on all our social media platforms, Facebook and Twitter, and connect with us on the website so that we could share all of these resources. Thank you, everyone.